Thank you very much, Charles, and indeed thank you to all of you for the opportunity to be with you this afternoon. Let me just start with a quotation, not from the Bible in this case. A friend of mine said to me a little while back, you might think about a year ago probably, he sent me a little text. He lives in France. It was from the quote from the German philosopher Schopenhauer. He said, "All truth passes through three stages. At first, it is ridiculed. Second, it is violently opposed. Third, it is accepted as being self-evident." I think we're probably lying somewhere between phases 2 and 3 at the moment. The truth in this instance is that to protect the NHS and to sustain the values of the NHS for the future, the NHS needed reform. Reform to promote clinical leadership, to empower patients in shared decisions about their care, and a relentless focus on the quality and outcomes of services. Those are the reforms you are pursuing. Many of you actually have argued for this for years. I can vouch personally for the fact of being with NAPC in years past where people have said, this is what we want to do. We want to be clinical leaders. We want to deliver better outcomes. We believe in patient-centred care. Nothing new about that. I make no claim in that sense of originality at all. Many of you have argued for these reforms. Many of you have sought to demonstrate them over the years. Many of you have equally seen false dawns when you thought reform was happening only to find it snatched away. This time it is happening, and we will see it through. Why? Because the NHS is too important for us not to do so. Of course, many people interpret the importance of the NHS as meaning that it must never change. To them, its bricks and mortar are part of the national furniture, an old friend, a trusted and loved institution, a fixed point. But the NHS is actually more than that. It's not part of the furniture, it is a service, and a dynamic one at that. The fixed point in the NHS is its values. The principles which were there at the outset, incorporated into the NHS Constitution, strengthened in this year's Act. But while values endure, the service can and will change. I'm only as determined as I am to bring reform to the NHS because I see the risks of inaction. I know, as you do, that the demographic tsunami that threatens to overwhelm healthcare systems in this country and others in the decades to come will overwhelm us if we don't embrace change. I know that while the NHS is great in so many ways, it can be better. We've been talking about this for years now, of the need for the NHS to redesign pathways of care, to reform services, to release the resources needed to reinvest to meet rising demand. But we've seen in the past, faced with these kind of pressures, as happened in 2006, for example, the response was to cut budgets, to ration care. But the new and the right approach is to innovate, to be clinically led. The NHS can never and should never be run solely on the bottom line. That would be entirely at odds with the values of the NHS to provide, and the values of the NHS are to provide a free and comprehensive health service. So we need always to look to give patients and the public the very best service and achieve the best outcomes. But at the same time, we do also need to spend what are inevitably finite resources in the most effective and efficient way. Now, of course, people say these two things are in conflict. But the reality is, that's life. We live with the need to balance both of these things. And the ethical responsibility, in any case, is to deliver the right care at the right place, at the right time for each patient. And as you do so, that's also going to be the most efficient and most effective response for patients. So you can be ethical and efficient. In truth, by being more efficient, it is more ethical, because the best for the patient in front of you must always be as well considered in the light of what is best for all of your patients. Two goals pursued at the same time with equal vigour. And for me in the National Health Service, and it's a central principle I've told many audiences over the years, is that given these two objectives, the only way in the National Health Service in which the best for the individual patient and the best for the population you look after can be brought together is for those decisions to be made by the same set of people. The people who make decisions about the care of individual patients should be the people collectively who take decisions about the shape of services that they need in order to deliver the best care for that patient. That's called clinical commissioning. And those people are you. Now, before this can happen, we need to move from one system to the new. I know that transition is tough. It's going to take a while to get used to the new way of doing things, working out your individual place within the new system. But I do ask, think not only of the immediate difficulties of change, but look to the opportunity that change presents. An opportunity to look again at every aspect of how the NHS delivers care, to see where it can be made better. To look at the wider health of the population, to see how we can be a healthier people leading healthier lives. To look at social care and see how it can be better integrated with the NHS for the benefit of millions of those with care needs. We'll only achieve that level of change through radical thinking, radical action, and a determination to keep moving forward. Now, sometimes that will lead to difficult decisions. Sometimes improving outcomes means reorganising local services, focusing specialist services in a smaller number of centres of excellence. Sometimes delivering services not further away from people, but closer to people. Services which are out of hospitals and in the community, in people's homes. While rarely will care settings close down, many will see their roles change. Sometimes that change will be significant and difficult. We know, for example, there are some hospitals where change is needed. Hospitals with long-standing problems that can no longer be swept under the carpet. We can't just keep kicking the can down the road, diverting hundreds of millions of pounds away from patient care to cover up deficits. Difficult decisions and strong leadership will be called for, but we will help. We will help the boards of those trusts, extending loans to give them the time and space they need to become sustainable, and as I said last year, assisting them with their PFI debts. But help does not and cannot mean endlessly propping up organisations that can't stand on their own 2 feet. That practice has gone on for too long. It steals valuable funds from others. That's why, and the reasons I'm doing these things, from your point of view as commissioners, is because I'm asking you to use your budgets to deliver the best care for patients. I'm not asking you to use your budgets to provide for the deficits of the providers in your local health economy. That is going to be our job. It's going to be Monitor's job in due course. But what we're aiming to do is as quickly as we can to make sure that people start out with the problems of the past properly dealt with. So we're working with providers, and some of them it will take a few years. We're working with primary care trusts, and actually, I think, as we have said before, we are still intending with the NHS Commissioning Board that you should start April 2013 with no legacy debts. Won't be true in the provider sector, but it can be true, and I hope it will be true, for you in the commissioners. But across the NHS, the scale of the challenge does mean we can't leave services in aspic. Decisions will need to be made, bullets will need to be bitten. I know there are many in the NHS who express scepticism about politicians and whether, when the chips are down, they will back difficult decisions. Actually, of course, the point is not that national politicians should make the case for local change. It's for local clinicians and local leaders, the NHS and local government working together, and you are working together more closely, to lead the case for change with your patients and the public. Do that, and I will back you. In the past, when politicians have failed to support difficult decisions, it's not because they lost their nerve, not only because they lost their nerve, it is actually because when they looked at it, the changes proposed weren't always clinically led. Too often they weren't backed up by clarity of evidence. Too often they weren't supported locally because the case for change had not been made locally. So the 4 tests I set out 2 years ago, the support of local commissioners, support of the public, clear evidence of clinical benefit, consistency with current and prospective patient choice, these must be your guide for making difficult decisions. But often the decisions will not just be about correcting ongoing problems, they will be about innovating to make services better. Seeing the opportunities that new technologies, new ideas, new ways of working present to us for improving patient care. Look at innovation, for example, around the NHS 111 number. Of course, technologically speaking, it's an opportunity that we didn't have 10 years ago, but it's an opportunity for much more than simply being able to say, yes, wherever you are with your mobile phone now, that we have the technology to identify your location and route you to the right call handling system. It's so much more than that. It's the ability to put a directory of services behind that call and to be able not only to respond to the call, but to connect up services and mobilize them. Give you an example. I was up with the 111 call handlers in Newcastle, and a lady rang, and she said her husband, he'd been at the hospital and he'd had a wound, and he was home now and he'd been home for a few days, but the wound was opening up, and what was she to do? Now, it's no criticism of NHS Direct, but in the past, of course, if that lady had rung NHS Direct, she'd have got advice, but the advice basically could only have been, under those circumstances, to go and visit the A&E. The reality of 111, of course, was listening to that. The call handler was able to say, absolutely fine, this is, we'll connect you to the district nurse service, I'll arrange for the district nurse to visit this afternoon, I'll call you back shortly, and a few minutes later she could call her back and say she'll be along at 3 o'clock. It's a simple example, but listening to the lady on the other end of the phone, she's going, really? Can you? And that's what we can do increasingly. We can have that kind of, yes, we can kind of moment in the NHS. We can do these things. And it's simply about organising the service behind the gateway in a way that is really connected up and responsive. Or look at year of care. The thinking that is going on now about how we can have a more joined up integrated service. And as commissioners, you have the power to say, right, okay, what we want is if we want a year of care and we want providers to link themselves up and to be responsible for that, we have plans for how we can have a year of care budget that enables that to happen. We can commission for the service that we want. And we have the tariff and the mechanisms and the contracting mechanism to make that happen. Or look at innovation on telehealth, the 3 million lives. I was in Kirklees, I was talking to a gentleman who had COPD and asthma, and I think in the 6 months prior to his telehealth system being put in, he'd been to the emergency department 3 times. But there he was at home, he was managing his medication well, he had his telehealth system, he was explaining to me very carefully about his blood oxygen level and 95% where he needed to be. And I'm thinking, a few years ago, he wouldn't even have known these things, and now he's managing his care at home and he can talk to the district nurse, but actually the district nurse came and she said, well, actually, I don't have to visit anything like as often as I used to. So this is empowering for the patient and efficient for the service. Or look at NHS Gloucestershire, where remote monitoring of patients with long-term conditions is being now rolled out across the country. And Dr. Graham Wilson, a GP there in Cheltenham, said, being able to monitor vulnerable patients means I can be proactive, providing them with the right support when they need it. Such timing can be critical in changing a patient's health outcomes. Now, the whole system demonstrator programme was published. Initial results showed a 15% fall in A&E in attendances, a 20% fall in emergency hospital admissions, a 45% fall in mortality rates. The first of the academic research papers resulting from that programme were published in the BMJ last Friday. Innovation and change will define the future of the NHS, led by the evidence of what works, led by local clinicians, not by men in grey suits from Whitehall, not even this man in this grey suit. Any changes need to lead to better outcomes for patients. The system needs to stop judging and rewarding people on the basis of how they do things, ticking boxes, hitting process targets. It needs to reward people increasingly for what is achieved for patients, the results and health outcomes. In the new National Health Service, the objectives, from my point of view, for improving care will be set out in the mandate. A central document for holding the system to account, essential we get it right. So I do hope that you will play a full part in looking at the draft mandate through the consultation, helping through that to shape the objectives and the direction of the National Health Service. From next April, that mandate will be how the Secretary of State holds the system, you, the NHS Commissioning Board, as partners in NHS commissioning to account. As I said, not for how you do things, but for what you achieve. 6 years ago, more than 6 years ago, David Cameron and I said, we do not want to be telling you how to do things. We want to be clear about what we're setting out to achieve, but let you, the professionals, decide how you achieve those results. So we'll set objectives, stretching goals, Parliament and people being able to see how clearly those results are being achieved nationally and locally, but the leadership and the delivery of those results is down to you. The objectives, as you know, will be built around the outcomes framework, preventing people from dying prematurely, enhancing the quality of life for people with long-term conditions, helping people to recover from ill health or injury, ensuring people have a positive experience of care, treating people in a safe environment, protecting them from harm. Those are the 5 overarching objectives. 60 indicators under those, things like ensuring people feel supported to manage their long-term condition, or improving recovery from stroke. And I think from my point of view, what I think is most exciting is just how many of these things that are really important were never measured. You know, the NHS never actually measured, for example, what mothers' experience during childbirth was. What was being measured was midwifery to mothers ratio and how many children died. But actually we should be asking mothers, after they've had a baby, did they have a good birth experience? We should be asking, and we intend to ask, children what was their experience of care, because the NHS didn't, the patient survey only began at age 16. We never asked children. We've got a programme with people with learning disability who are designing a mechanism by which they can feed back on care. These are really exciting new ways of getting feedback to the service. So the outcomes framework will set that direction. It'll focus all of our minds. It will enable, most of all, frontline clinicians to lead and not to be micromanaged from on high. The mandate will embody the values of the NHS. A free, comprehensive service available to all based on need, not ability to pay. Not a ration service. It is a comprehensive service. We don't expect people to be able to provide their health care privately. They are part of the NHS. But it has to be a service which is also clear about clinical effectiveness. We are not asking you to offer treatments of no clinical benefits, nor those which are of poor value. And we have to move away from thinking that hitting a few narrow, politically convenient, process-based targets is an adequate or sensible way to measure the performance of the NHS. It's not. We need to improve services across the board. Yes, people shouldn't have to wait a long time for treatment. You know that. But they should also be confident that the treatment they receive is worth waiting for. People should know when their local hospital and their local GP practice is good and be able to see how good. And if it's not good enough, then they should know that they can choose another. In the NHS, care must be designed around patients. They will be empowered to control their own health and care far beyond what is now the case. All of the NHS bodies will have duties to consult and engage with the public. But beyond that, no decision about me without me, the principle of shared decision-making will be the order of the day. Patients empowered to choose the best treatments and the best place for their treatment, armed with the best and most relevant information. But actually not just empowered with choice, but engaged and involved in every decision, at every stage of their care. And using the power of information to make it happen. We published the information strategy just about a month ago. Things like internet and smartphones, things that actually in every walk of life people treat increasingly as normal, will enable us, with openness of information, the power of information across the health service, for people to access services more readily and indeed to be able to share in decision making much more effectively as well. Big data having a big impact on all of us across the health service. Now, the mandate will also ensure the whole system focuses on improving outcomes for everyone, including on improving the outcomes of the poorest fastest. Where you live, the community you belong to, your family history, all have a huge impact on your health. But generally, the better off you are, the longer and healthier your life will be. And I think we're all aware of the apparent perversity that the better off you are and the more affluent the area you're in, very often, the more access you seem to enjoy to healthcare. So one of our objectives, one of your objectives, I know, will be to reach to those who have the least access to healthcare, for whom the health outcomes are poorest, and to reduce those inequalities to ensure that we genuinely lift the outcomes of the worst fastest. Also vital, if we're to improve outcomes, will be to give people far more integrated care and support. The services that meet their wider needs. That's why I feel so strongly about not only the way commissioners can integrate health services, but the opportunity through health and wellbeing boards to reach out across all the services that make such a big impact. You know from the patients you look after that very often you have to deal with a housing problem alongside a health problem. You have to deal with an employment issue. You have to deal with people's relationships at work, how much mental health problems that you see are actually bound up with issues related to people's work or lack of work. So tackling the health needs of the patients you look after and the population you look after through the health and wellbeing boards, you can do so much more. And local government will be alongside you. Tomorrow I will be with the Local Government Association debating exactly these issues, because they want to be there with you making these things happen, understanding what the wider determinants of health are and impacting on them. So bringing together the NHS, adult social services, children's services, public health, counsellors, patient groups like Healthwatch, all part of making this happen. And I hope doing it in a way that isn't bureaucratic, because actually in any locality very often these relationships can exist without a bureaucratic process. There's a health and wellbeing board and you're part of it. You're the clinical commissioning group, you're responsible for commissioning healthcare. The local government the council is pretty much responsible for commissioning those other services. Get together. And I have seen in places where was I? On the Wirral just a few months ago, seeing how precisely those same people, or in Leicestershire just a few weeks before that, seeing all those people round the table, literally having all of those conversations. Sometimes having conversations now, creating relationships that never existed in the past. I mean, I was where was I? In Salford, I think, and the GPs and the counsellors, the counsellors have been counsellors in that area for years. The general practitioners have been GPs in that area for years, but they'd never actually created a relationship and understood that they had literally a shared population that they looked after, but they hadn't discussed between them how they were going to go about doing it. Now you can. Now you should. Of course, it is a transition period, and I am looking to the NHS Commissioning Board to give support through that transition, not least in helping as many CCGs as possible to be fully authorised as quickly as possible. To spur on this process, this week we set out in Parliament regulations which ensure a transparent process for authorising CCGs and a framework for effective governance, involving lay people and health professionals as well as general practitioners. A primary role for the Commissioning Board in the coming years is to give CCGs the support they need to establish themselves and then to thrive, to ensure that each CCG in the country is strong enough to give local patients and local people the NHS they deserve, to be the local leaders I know you want to be, to enable all of you to be as good as you possibly can be. Now, I know there are some urban myths. There are always urban myths. Things, the one about the board top slicing your budgets, or that you have to be reauthorised every year, somebody said to me last week. Neither will happen. They're both nonsense. The board will have its budget, you will have yours. And once authorised, you as CCGs will have the authority to commission care, accountable for living within your budget and for delivering improving results, but not subject to constant reauthorisation. And the conditions we're looking for if they are applied, and in many cases they will not need to be, will be transitional, not permanent. Now, as we go into the summer, it says in my speech here, we're entering the summer. I suppose it does. I'm kind of hoping it is. I have one or two things I have to complete where we said we'd finish them in the spring, so it can't be summer yet. It's a myth in Whitehall that summer arrives. But as we go through these few months ahead, there is, to my mind, a real sense of momentum. The system is taking shape. Difficult as it is, people are understanding what it looks like and where they fit into it. Next month, we will see the first wave of CCG applications submitted. Across the country, services I see being redesigned, we actually see outcomes improving, and we see costs under control. In fact, general practice is you are already shaping the NHS. Reduced GP referral rates, fewer emergency admissions. No evidence that this is referral management at the cost of emergency admissions or A&E attendances, nothing like that. Actually, they're all consistently moving in a direction that says patients are being managed well. That's important, and I'm grateful for it. And I think it's about the new relationships that are already being forged to build services that are community-based with primary care leadership, but alongside your specialist colleagues. With specialist nursing and consultant colleagues and specialists in the hospitals, really trying to reshape services so that it isn't about primary care and secondary care, it isn't acute versus primary. It's actually about understanding that we have a community-based service primarily, which includes specialisation, which is designed with specialists, where specialists can be there in the community as much as they may be there for other purposes in a high-intensity acute setting. So I know it's difficult. I know change always comes with some friction, but I do encourage you now to look ahead to when the system is in place. The job that I know you're all motivated to do is the only job you really have to do, which is to improve people's lives through commissioning and delivering better healthcare. Looking ahead to a time when you will be in charge, held to account, in a challenging environment, under pressure to deliver, but able to control your own destiny and the healthcare for your local community. Look ahead to working with local people and local organisations in the new health and wellbeing boards to make sure care is integrated, excellent and efficient. Look ahead to working with patients to ensure they are able to shape their own care and collectively to shape with you the local services they enjoy. Look ahead to the new NHS, and I hope you will agree that the changes you will lead will deliver the constantly improving NHS we all seek. As Schopenhauer also said, change alone is eternal, perpetual, immortal. You are leaders for change, leaders for the NHS, leaders for quality, and leaders on behalf of your patients. And for their sake, I wish you every success. Thank you very much.